Hello, my name is Tawfik Khoury, gastroenterologist, specialist in EUS and ERCP. I am happy to present to you our study led with Dr. Andrea Lisotti from the Hospital of Imola, Bologna, Italy, and Dr. Bertrand Napoleon from Private Mermoz Hospital, Lyon, France, on EUS versus ERCP, a guided primary drainage of inoperable malignant distal biliary obstruction, systematic review and meta-analysis of randomized controlled trials. In fact, me and my colleagues were motivated to do this systematic review and meta-analysis as we saw that in our clinical practice, ERCP in patients with distal malignant biliary obstruction is a challenging procedure with a potential serious adverse events. And given the increasing evidence of EUS-guided biliary drainage in the recent years, and recently the two papers that were published in gastroenterology on lumen-apposing metal stent in those patients, we were enthusiastic to assess the efficacy and the safety of ERCP versus EUS-guided biliary drainage as a primary treatment options for the patient with malignant distal biliary obstruction by including head-to-head randomized control trials. From here, my colleague Dr. Andrea Lisotti will present the results and the discussion of our meta-analysis. Thank you.
Thank you, Dr. Khoury. These manuscripts report the results of a meta-analysis including 5 high-quality randomized controlled trials assessing the difference between EUS biliary drainage and ERCP in patients suffering from malignant distal biliary obstruction and included more than 500 patients. The results revealed several important findings. First of all, EUS-guided biliary drainage and ERCP showed similar technical success rate with a 1.06 relative risk, similar clinical success rates without any significant difference in the incidence of adverse events and procedural mortality. Interestingly, while 1-year stent patency rate was comparable in the two groups, patients into the EUS-BD arm had a significantly lower need for intervention compared to those who underwent ERCP. The relative risk is 0.58 with a p-value of 0.01. Moreover, the procedure time was significantly shorter for EUS biliary drainage with a standardized mean difference of more than 2 minutes. We conducted a subgroup analysis according to the type of stent used for EUS biliary drainage, either self-expandable metal stents versus lumen-apposing metal stents. Notably, EUS-BD performed with lumen-apposing metal stents demonstrated a significantly higher technical success rate over ERCP with a relative risk of 1.17 and a p-value of 0.03. In conclusion, this study demonstrated that while both EUS-BD and ERCP provide similar efficacy and safety as primary intervention for distant malignant biliary obstruction, EUS-BD may have the edge with a lower reintervention rate and shorter procedure time. Furthermore, the use of lumen-apposing metal stent for EUS biliary drainage might provide even better technical success rates compared to ERCP. These findings suggest that EUS-BD, in particular with lumen-apposing metal stents, could be considered a viable primary intervention in high-volume centers with expertise in these therapeutic procedures. Finally, while this meta-analysis corroborates the potential of EUS-BD as a first-line intervention in certain clinical scenarios, it underscores the importance of individualized patient care, selection, and multidisciplinary discussion. Thank you for watching this video, and for detailed information, I suggest to read the full manuscript on Endoscopy Journal or to contact us for any discussion.